Hello everyone. Welcome to the next in our series of Policy Plus webinars. Today's webinar is focusing on HRSA credentialing and privileging. Our presenter today is Dr. Amelia Broussard. She's been working with HRSA and other organizations doing federally funded consulting for federally funded organizations and HIV/AIDS foundations since 1996. And I'd like to allow Amelia to step on and give you some details about her background.
Okay. Can everyone hear me?
Yes, the audio is very well.
Oh. Okay. So good afternoon, everyone. I'm going to be talking to you about the HRSA credentialing and privileging requirements. This heavily leans toward FTCA, but if you meet those requirements, then you definitely will be meeting the requirements for HRSA. So it's very important that we get those activities taken care of. This is kind of an overview of the session. We're going to have a brief overview defining what credentialing and privileging is. We're going to be looking at what are some of the insights for your participants on the importance of two functions. We're going to actually talk about what credentialing process means and some of the details for that, and then also the same thing for privileging. These two activities are usually done together rather than separate. So this is something that you want to keep in mind. So in our introduction, we have our FQHCs who are responsible for assuring care provided to patients that is done by competent healthcare practitioners. This means that we definitely have the people who say they are and that we have verified that they say that they are the right person. Participants are going to receive the critical elements of credentialing and privileging process. You'll also learn the importance of establishing and maintaining credentialing files, and then the files supporting the quality improvement and patient safety activities. Okay, so will accreditation fulfill, oh, excuse me, we need to go back one. I missed one real quickly. All right, what is the importance of credentialing and privileging? First of all, it ensures that all of your healthcare providers, and we're talking about LIPs, which are licensed independent practitioners, and clinical staff, typically your support staff, or other licensed certified HPSs, are qualified to provide the type of care for which they are employed. It involves evaluating a practitioner's eligibility to provide clinical services at your health center, and it also evaluates the provider's competency for specific clinical privileges. And we'll talk a little bit more about that here in a minute. Failure to fully credential may result in liability if a patient is harmed. So we want to fully credential all of our licensed independent practitioners and our other licensed or certified health practitioners to make sure that they meet all the requirements for your state as well as for FTCA. Now, one of the questions that I have gotten many times when I'm out doing operational site visits is, will accreditation fulfill the FTCA requirements? There are definitely commonalities between accrediting bodies and FTCA. So one of the things that you will have to do is, first of all, download PIN 2002-22, which gives you all of the FTCA credentialing and privileging requirements, and then based on that PIN, look at the accrediting body to see if their credentialing and privileging requirements are very much the same as the FTCA. There is also the 330 expectations, program expectations. If you look at the site visit guide that is used to conduct the operational site visit, you will also see requirements in the site visit guide itself, particularly if you look at program requirement number 3. That's where credentialing and privileging is typically reviewed by your operational site visit team, and there should be information in there that can help you. Lastly, but not least, is our state requirements. We want to make sure that we're meeting all of the requirements according to the state in which you are located. Each state has a practice act for both the medical practitioners as well as nursing staff, and that also includes the nurse practitioners. Physician assistants would be found under the medical board. So one of the things that you would need to do is make sure that you have copies of the practice and the Nurse Practice Act of your state to assure that you have all the information that they also require. If you are in doubt and you're not really sure if your accrediting process is going to meet the FTCA requirements, follow FTCA because it tends to be more rigorous than your accrediting bodies, and if you meet the FTCA requirements, you're going to meet the expectations for HRSA. So, licensed or certified healthcare practitioners. One of the things that you will clearly need to define is who you consider a licensed healthcare or licensed independent practitioner. This individual is permitted by law and organization to provide care and services without the direction or supervision within the scope of the individual's license and is consistent with individually granted privileges. Typically, the individuals who fall in this category are physicians, nurse practitioners, physician assistants, dentists, nurse midwife, behavioral health, and in this case, we're generally looking at psychiatrists, although many organizations also include the licensed clinical social worker in this category. The other category is the other licensed or certified healthcare practitioner, or OLCHPs. And these are individuals that are not permitted by law to provide patient care without direction or supervision. And the examples here would be your lab tech, your social worker in some cases, the laboratory X-ray medical assistants, registered nurses, licensed practical nurses, and dental hygienists. Dental assistants would also fall in this area as well. Now, some states do not require any kind of certification for medical assistants or for certified nursing assistants. However, you can get information on their training and can set up a competency to assure that these people are able to perform what you need them to do. Now, this is an attachment E and is a sample of what you would typically submit in your FTCA application. The first things that you would want to include in column A is the first name, the next comes last, title, professional designation, etc., etc. Some of the things that you want to make sure are correct is, first of all, the date of hire or when you contracted with this individual. Also, you want to know when their current credentialing date is. For example, in the state of Georgia, where I reside, registered nurses and physicians are renewed every 2 years. So my current credentialing date is January 1, 2016. So I will have to renew my license at the end of this year. The next re-credentialing date would be when I would have to renew that license to be to maintain that license status. I'm not going to read all of this, but just wanted you to pay attention to this. Now, one of the other things that I would mention to you is that there is an expectation that you're going to include all of the individuals who are in your clinical staff. This could be your licensed independent practitioners, and here is a slide actually talking about that. So who should appear on the credentialing list? In this case, it would be all health center practitioners who are either employed, contracted, volunteer, or locum tenens. And of course, the locum tenens are the temporary practitioners that you may hire to fill a vacancy until you can fill that or fill that spot again. And these would be at all of your health center sites. So if you operate more than one facility or one clinic site, then you would need to make sure that all of the staff that are currently employed to provide services at those sites are listed. The other thing that you would want to include is practitioners, definitely, and also all of your other licensed or certified practitioners. These are your registered nurses, your LPNs, your medical assistants, the dental hygienists, the dental assistants, all of those individuals who fall in that OLCHP category. Should employees from the past year or current employees appear on the credentialing list, the only people that would need to be on this list when it is either generated for FTCA or for your operators shown on site visit should be the employees that are currently working at the health center at the time of the submission of your application. So if you had somebody who was there partially for last year, you would not include them at this time. There are two issues or two areas that we look for when we're starting to do credentialing. One is considered primary source documentation or verification, and secondary source. In PIN 2002-22, there's a very nice list of what FTCA expects to see as primary source verification. And this is just kind of a general listing of some of the things that you would expect to do this. Primary source is verification by the original source of specific credentialing to determine the accuracy of the qualification reported by a practitioner. You would want to get direct correspondence, perhaps from someone at their training location. For example, all of the medical providers in the United States have a internship and residency program, so you would definitely be able to receive a letter from that residency program verifying that this individual actually did complete their residency at that time. You can also do telephone and or internet verification. If you do telephone, you do need to be very specific. Number one, date, time, as to when you talk to this individual. You need to make sure that you have the full name and credentials of the individual, such as director of the residency program, and also that they were able to confirm the residency or the training program that this individual participated in. There are other kinds of things that you can get. For example, websites such as the Education Commission for Foreign Medical Graduates. The American Board of Medical Specialists would also be able to give you information on this. The American Medical Association is something that is used quite frequently to verify education and training. And also you can get the same information for boards of nursing within each state. So if you have nurse practitioners and you need to verify their licensure, or registered nurses, LPNs, you'd be able to do so through the Board of Nursing. Now, the other thing that you can get are credentials from a verification organization. The only caveat with the CBO, as they're typically called, is that you need to have a policy and procedure in place that dictates exactly what information they're going to provide for you and how they're going to provide that. So that when someone comes out to look at your credentialing files, which we'll talk about shortly, they will be able to find all of the information that you had indicated in your policy and procedure. Now, one of the other things that we do suggest when we're doing operational site visits is to receive official transcripts from schools of medicine and schools of nursing to verify all of the education. People say, oh, this is expensive. Well, actually it's not, because what you do is you have that individual request their transcript from their educational institution and have it sent to you directly. It must say official transcript or it is not considered an official transcript. If they bring it to you, do not accept it because it needs to be sent to you directly from the institution. The next thing we want to talk about is secondary source verification, and this can be verification by sources other than primary sources. For example, you might have an original or initial credentialing, something as a copy of a current license. If you're going to do something like that, I do recommend that you request the individual bring you the original copy so that you can actually verify that it was issued by your state and is current, and then you can make a copy of that and make a notation that it was copied. You can also get a notarized copy of a credential, in this case license, or if we're talking about a physician, nurse practitioner, or PA, you probably have a DEA number as well as the NPI numbers that they get. We just need to make sure that it has been approved by the health center staff and that you have actually seen the original. Again, the source for a lot of this is from PIN 2002-22, so I do recommend if you have not downloaded this PIN that you do so real soon so that you can get this information available to you. If we look at primary source verification for LIPs, these are the things that we want to see in a primary source, which means that this is something that we get from the original source itself. So this would be the applicant's license, education, training, experience, registration, any certifications that they have, current competence, applicant's ability to perform services for which privileges are requested. So we would need something that would give us an idea that this individual actually can do these kinds of things. Secondary source for the licensed independent practitioners is typically a government-issued photo ID. Usually I see copies of the current driver's license, although I have seen on occasion actual passports, which is fine too. DEA registration, if it's applicable. There are some licensed independent practitioners who do not dispense narcotics or do not have that ability to do so. But in most cases, your nurse practitioners and PAs do have opportunities to dispense or at least prescribe some what would be considered narcotic level medications, but they are limited to, I believe, class 3. Hospital admitting privileges. This is not necessarily as important as it was in the past. However, some of our community health centers are still requiring their providers to actually admit their patients themselves and follow them while in the hospital. If that is the case, then you would need to have hospital admitting privileges. Now, if an individual is coming from a practice that did require that, then that might be something that you would consider finding out, because it might give you some ideas about whether or not there were some issues. If this person was not granted hospital admitting privileges, then that may lead you to some other questions about this individual. The last part of that would be immunizations and your PPD status. We do like to make sure that providers have had up-to-date immunizations. We also want to make sure that they have been either tested for tuberculosis or have received a chest x-ray, depending on where they are coming from. Apparently there are still some countries, India I believe is one of those, who still administer a live PPD vaccine. When that happens, that individual is going to test positive with a typical tuberculin test. So that means that they would have to have a chest x-ray to verify that they do not have that information. Now, one of the things that is useful to the individual who is doing this, as far as doing the credentialing itself, and by the way, this is typically done within the Human Resources Department. It doesn't need someone with a special education. It just needs somebody who is what I call extremely detailed and a bulldog, because sometimes it takes a while to get all of the information. It is helpful to use a checklist, and there is a checklist in PIN 2002-22 that you can use that can assist you in making sure that you have everything. But these are typically the things that we are looking for when we're looking at operational site visits in the credentialing file. We want to see a curriculum vitae that gives us all of the dates of employment and also has information that explains why the individual was not working if there are gaps. Verification of education, we talked some about the transcript. Statement confirming health fitness. Some organizations actually have the individual go through a physical exam by one of the providers on staff, and that then is confirming that the individual is able to provide the services for which they are being hired. If there are any certificates, for example, board certification, basic life support, or ACLS, those would be something that you would definitely want to get. Medical licenses, which can be obtained through the Board of Medicine and or Nursing. Drug enforcement or DEA registration, controlled dangerous substances, if this is required within your state, and then peer references. These would be individuals who had worked with this person in the past. If it is a newly confirmed physician, then you would probably get the peer references from their residency program, and they may suggest to you individuals to contact at that point. Some of the other information that you'd want, particularly if this individual is coming from a former practice, you'd want to know that they had proof of liability insurance. You'd definitely want to have a summary of malpractice claims or adverse actions that have been filed. One of the big things that is required, particularly for the licensed independent practitioners, is the National Practitioner Data Bank query. However, we also recommend that you do that for your other licensed certified healthcare practitioners as well. All of the medical staff at this point in time are on the National Practitioner Data Bank, and it's a good idea to have that done for all of your medical and clinical support staff. Delineation of privileges is something that definitely needs to be done. We want the government-issued picture identification, immunization, life support. We talked about fit for duty. And then verification of hospital and or facility privileges. So there are some other things that you can look for. For example, there's a website here from ECRI. If you have not joined ECRI, this is a good time to do so because it will give you some information that you need. Our next slide talks a lot about some of the same information, but this is for other licensed certified healthcare practitioners. This is the group that typically is left out of credentialing and privileging. When I do an operational site visit, I will see great information on the licensed independent practitioners, but the ones who are not well documented are our other licensed or certified healthcare practitioners. So this is the information that you typically need to have on a bare minimum for these individuals. Again, this information is listed in the PIN 2002-22. You need to include this process in your credentialing policy and procedure so that we know that you definitely are collecting this information. The main thing that you would get as a primary source verification for other licensed certified healthcare practitioners is the applicant's license or certification. And then the rest of the information is secondary source verification. Education, training, experience, you would definitely want to try and get official transcripts if at all possible, or something particularly in writing for medical assistants, at least giving you some understanding as to what they did. A lot of times I will see certificates for medical medical assistants. However, I would point out to all of you that Publisher does a really nice certificate, just in case you haven't noticed that. So I really would encourage you to try and get as much information from the individual about where they completed their training and their experiences, and then you actually pursue some kind of documentation that will verify that completely. Registration and certifications, current competence. Typically we have competencies for all of the nursing staff, depending on what level. For example, medical assistants may not have the same level as, say, a registered nurse. Again, you would want to have a government-issued ID, typically driver's license. We generally do not see DEA registration for these individuals, but we would want to see their immunization status and their PPD. Immunizations typically consist of things like flu vaccines, Hep B, hepatitis C, if that was something that was available to this individual, and then there may be some other kinds of things that we want to look at. This is the checklist from PEN 2002-22. This one refers specifically to licensed or certified healthcare practitioners. I'm not going to read over all of this. It's much easier for you to see if you look at it in the actual PEN itself, but it does kind of give you exactly who would be in what area. So, for example, these are all the things that are required for the physician and the dentist. These are all the things that are required from for the other licensed certified healthcare practitioner. The other checklist that I wanted to point out to you is a re-credentialing process, which I think a lot of people forget about. But this also includes the initial granting of privileges, and then we have the renewal or revision of privileges, as well as re-credentialing for these individuals. This typically is done every 2 years, depending on your state. For example, when I was in California earlier in the year, I was informed that California conducts or renews licenses every 3 years rather than every 2 years. So one of the things that you need to make sure is that your policy and procedure definitely is following your state requirements. You will find that in PEN 2002-22 that there is, if there is a requirement of the National Practitioner Data Bank to be queried every 2 years. That in itself is not a bad thing, but just remember that may be out of sync with the license renewal. Typically, we like to see re-credentialing, re-privileging in that National Practitioner Data Bank query conducted at the same time. So, credentialing files. This is a really important piece in the process, and this is something that people forget about on a regular basis. I have seen some extremely organized individuals where they have everything tabbed, put into either notebooks or divided folders that gives you a very good and clear picture as to what is actually maintained in those credentialing files, and I can find all of the information that I need to find. In other situations, I have gone in and it's nothing but a file folder, and everything has just been stuck into the file folder, and there's no organization at all. This makes it very difficult to review and to assure that the organization is complying with their policy and procedures. And I would say that I can't imagine that the organization itself is able to do some of the same things that they need to do. For example, you need to regularly identify your expiring credentials before they expire. It takes sometimes as long as 60 to 90 days to get these things renewed. So it's very important that we review the file at least once a year to identify any missing items so that we can maintain those records and also make sure that our providers are giving us the information that we need. If we decide to use a credentialing or credentials verification organization, again, you need to ensure that the CDO understands your requirements as an FQHC. Your contract should speak to privacy, who owns the documents. For example, once they have compiled all this information, where does it reside? It should reside at your house, not at theirs. So your contract should say that they're going to provide this information to you so that you can maintain a current file. Same thing with document retention. How long will they maintain records for you on your providers? You need to make sure that your privacy release, which is signed by the licensed independent practitioner, speaks to the use of a CDO by the organization. In other words, when you ask your licensed independent practitioner if this organization can investigate them and provide the necessary verification of licensure and the rest of their credentials, then there must be something in a privacy release that that individual has signed that grants that permission. Last but not least, your policy and procedure really does need to make sure that you include all of the information that's expected for your CBO, as well as what they're going to provide for you and what documents you are going to provide yourself. Now, credentialing files for nurse practitioners and PAs. Essentially, these individuals are considered LIPs, so they would need to meet all of the requirements of the state licensing boards to practice. In this situation, nurse practitioners would be under the Board of Nursing and physician assistants under the Board of Medicine. Nurse practitioners must have a collaborating agreement with a physician in their credentialing and privileging file. I usually recommend that we have the same document in the physician's file as well, so that everybody is aware as to who's doing what. PA must have a supervisory agreement, and I also suggest that you have the same situation as we do for the nurse practitioners. If we have a supervisory agreement for the PAs, it should be in both the PA's credentialing file as well as the physician who is serving as a supervisor. Now, we want to separate our credentialing and privileging from the personnel information for LIP specifically. We do not necessarily want to include information in personnel records such as our credentialing privileging, because some of the other information that goes into that file may be discussions or comments regarding adverse situations in which this individual had to answer to allegations regarding malpractice. That's not information that you'd want to have available in a personnel record. The other thing is, when we look at the other licensed certified healthcare practitioners, in many cases it's not practical to actually maintain a separate credentialing file. However, what we do need to do is segregate an area within the personnel record that is maintained in a separate section that includes all of the information that would assure that this individual has the correct credentials to do what they are doing within. If you are not using a divided folder, I would recommend that you get those. You should look at the ones that have at least 5 tab sections for better organization. And let's face it, it also helps you find the information itself. A lot of the information that you use to actually verify the licensure is the same information that insurance companies require to have your providers credentialed within in order to get paid. So the easier it is to find the information, the better off you're going to be. I also recommend that you set up a tracking process either in Excel or even just a good old-fashioned tickler file to assure that all of your credentials and privileging are renewed on time. And then we also want to maintain copies of our Board of Medicine requirements and the Board of Nursing requirements for all clinical staff. This will assure that you are meeting those requirements just like you would for FTCA. Now,
Amelia, this is where Policy Plus can come in. This is where it will, program actually will take all of this process as we're talking about here and automate them, and then send out alerts when it's time to either renew the credentialing cycle, or in the case of individual credentials when they're up for expiration, sends an email out to whoever is the credentialing supervisor as well as the individual employee to keep them proactive and nothing has to keep all this up. And it digitizes all of this. It takes away all that extra work with keeping up with the paper, and you scan it, we upload it to the program, and it's available to anyone with internet access. You log in, you have access to it, just like online banking and online shopping.
That's great. That's a perfect way to make sure that you are keeping up with all of your tracking and everything else. I have seen some programs or organizations using that, and that seems to be very good. However, not everybody is up to speed on the electronics, so any kind of process that works for you is fine. But obviously, if you wanted to go that route, that would be good. The other thing that I would mention on the privileging is that we want to make sure that our privileges are related to the specific services that you're providing at your health care or at your health center. These things should be verifying all of the clinical privileges and medical staff membership at local facilities. They should be renewed just like our credentials are every 2 years or in tandem with your license renewal. And full and temporary privileges need to be clearly defined. In PIN 2002, it does give you an opportunity to grant temporary privileges, but you need to decide whether or not that's going to happen within your organization. If it does, there needs to be information included that would define what is considered temporary privileges and what documents need to be in place for that to happen. One of the other things that we need to do is our approved applicants are notified in writing within a defined time frame. This should be in your policy and procedure. Approved applications and a copy of the approval letter are forwarded to the appropriate internal personnel within a defined time frame. Applicants who have been denied are also notified within a defined time frame. So everything needs to be specified in your policy and procedure to make sure that there are specific deadlines that are met based on this privileging piece, particularly in case of an individual who is not going to be approved. And also the PIN 2002-22 recommends an appeals process for that individual as well. One of the last pieces that I really want to spend a little bit of time on is the board approval of credentialing and privileging. The board must be aware of all of your licensed independent practitioners that you have employed. Now, they do not participate in the actual interviews. However, they do need to know that you have hired these individuals. The staff complete the credentialing and privileging in the process itself, and then candidates are presented to the board for approval. One of the most important parts of this is that the approval must be documented in the full board minutes. This may not be done in committee. You may have a QI committee at the board level that actually reviews the credentials, and then they can make the formal recommendation to the full board. But the full board must approve all of the credentialing privileging, and then that must be documented in the minutes. And part of the reason for this is that it assures board oversight according to the current program requirements, and it also meets the requirements for FTCA. Also, if we deny privileges, we must document that in the board minutes, and we also need to talk a little bit about what happens to that individual at that point. So that would go into the other piece. I'm trying to rush through this for a minute so I can give you guys some time for questions. Peer review policy is something that definitely needs to be a part of your program. Generally falls under the direction of the chief medical officer. It does tie into the quality improvement. The goal here is to have the medical peer review to deliver standards of care and to improve the quality of care and patient safety. It helps individuals learn from past experience, errors, and near misses. We also want to connect peer review to credentialing and privileging. So some of the things that we would want to see in a policy is that who supervises the process and what are their responsibilities, frequency of the reviews, and the number of charts per provider, how feedback is communicated to the individual but also to quality improvement, and how is it documented. How is patient confidentiality maintained? This gets kind of messy or kind of hard to do when we have an electronic medical record, but there are mechanisms in place to do that. And then the other question is what methodology is being used when we're developing strategies for improvement. And this goes into the quality improvement process that we want this information to be considered. So how do we ensure compliance with the FTCA requirements? First of all, let's fully understand those FTCA requirements. In this case, our health center's credentialing and privileging policies must be approved by the governing board, and it either needs to be it has to be documented in the minutes, It is also very good to have a signature from a board representative, either the secretary of the board, in most cases it's usually the board president, with a date and time that this was signed. Credentialing and privileging procedures must be completed and documented, which means that we have a file that is showing that you have actually gone through all the steps that you have outlined in your policy and procedure regarding credentialing and privileging, so that we can go back and look at that and make sure that that is actually working correctly. We do want to have our credentialing processes and delineation of privileges reviewed by the Chief Medical Officer and or a committee. I have seen 3 individuals appointed, including the Chief Medical Officer and maybe the Chief Executive Officer and one other person, or you may have it made up of all medical providers, but a committee is definitely a good way to go about this. The reviewing committee must document the review of the specific providers, and then the information is presented to the board for approval, and they actually approve and credential the individual. Now, we can delegate to an organizational committee and be ensured that the organization is compliant. And the way that this happens is that a report has to be generated to the board. But typically what I see in the board bylaws is that the individual is going to actually present information to the full board, and they actually vote on that. There is a motion and a second, and then a vote is taken to approve those credentials. This definitely is the easiest and most effective way because it's documented in the minutes, so we don't have to worry about that. Now, one of the things that is very important to understand is that if you are going to grant someone temporary privileges to provide services, you need to inform the board. The board needs to be aware that you have an individual who has not completed their credentialing process fully. However, you have enough information to grant temporary privileges for them to practice until the rest of the information is there. I really encourage you to limit the amount of time or the number of times that you use temporary privileges for providers. This can really get into a habit, and what I have seen in one organization is that individuals were working before they were actually approved by the board of directors, and there was no indication to the board that this person had temporary privileges and had met those requirements or anything else. So remember, the board has oversight of your organization. They really do need to know who is practicing in their facilities, providing services, and that due diligence has been done to ensure that they are what they say they are, that they're not someone practicing under adverse conditions. Now, the other thing that I would recommend to you is that your risk management, corporate compliance, quality improvement, quality assurance programs should also audit the processes to ensure to ensure your policies and procedures were fully implemented and that your organization is compliant. Because this part is very important for you to have all of these things in place, and it gets into a real big problem if you are not in that situation. So that has pretty much completed the presentation, and at this point in time I think we have, 15 minutes